Choice of anesthetic in a patient with multiple sclerosis. There is some problems with subarachnoid block. Putting in local anesthetic and exposing those demyelinated nerves to high concentrations of local anesthetic may exacerbate MS. So SAB tends to be avoided. Epidural or peripheral nerve block is acceptable. We avoid succinylcholine because multiple sclerosis is a demyelinating disease. And if you have demyelinization and nerves that are not working well, and you expose extrajunctional receptors to succinylcholine, you can get a hyperkalemic response. If someone's on high doses of steroids, you consider steroid supplementation in the perioperative period. Patients with multiple sclerosis, if their nerves aren't working very well, they can have respiratory dysfunction. They have weakness of those respiratory muscles, and their breathing muscles, their minute ventilation, their forced vital capacity, expiratory weakness occurs, and they're at risk for aspiration and pneumonia in the perioperative period. But the major point of this keyword was that hyperthermia, even small increases in temperature, can exacerbate multiple sclerosis. The next group of keywords from 2018 are ENT and eye topics. Again, they are in green. The black represents about a decade of keywords. The times 3, times 4, times 2, etc. refer to how many times that keyword has shown up over the last decade or so. But we're focusing on 2018. One's in green: laser airway fire, thyroidectomy complications, jet ventilation complications, and then under eye, we'll talk about postoperative blindness, the cause of it, ocular cardiac reflex, and retinal detachment as sulfur hexafluoride. Laser airway fire, the first key word from 2018, ENT topic. How do we decrease the risk of laser-generated airway fires? There's 3 things that we can do. 1, if there's an endotracheal tube in place, reduce the flammability of that endotracheal tube. Use a steel one, for example, and the example at the top right is a steel tube, one with a cuff, double cuff actually, and one with no cuff. These stainless steel endotracheal tubes are the most resistant to lasers. The PVC tubes are very flammable, as are red rubber and silicon endotracheal tubes. So a stainless steel tube, most resistant to the laser and resulting in a reduced risk of fire. You can put saline in the cuff. You can put methylene blue in the cuff of these tubes so that if the laser happens to strike the cuff and it deflates, the methylene blue is spilled into the airway, and you see blue in the airway, and you can say, aha, my cuff is broken. Another way to reduce laser-generated airway fire is to reduce the available FiO2. Usually, we make it less than 30%, a mix of air and oxygen, with overall FiO2 less than 30%. We avoid nitrous because it also can support combustion. Another way to reduce laser fire is remove the flammable material from the airway. So don't even have something there that the laser could hit, and that would include intermittent ventilation or having a small endotracheal tube that's placed in, you ventilate, then remove it, and apnea occurs, and the ENT surgeon lasers during the apneic period, waiting for the saturation to fall. The saturation starts to fall, the tube is put back in, and ventilation occurs again. So stainless steel tube, keep the FiO2 less than 30%, and if possible, not even have an endotracheal tube in the airway during the time of the laser. Now, if an airway fire occurs, according to the ASA Practice Advisory in 2013, the very first thing that you should do, without waiting, is if that tube is on fire, pull the endotracheal tube, number 1. Then stop the flow of all airway gases, flood the surgical field with saline, ventilate the patient, put a mask initially, and then re-intubate them, and consider bronchoscopy if there's pieces of endotracheal tube, or you need to investigate for a burnt airway. Thyroidectomy complications is the next keyword from 2018. There are 3 things that we're going to discuss: nerve damage, parathyroid injury, and bleeding into the neck. First, nerve damage. Superior laryngeal nerve has both an external and an internal branch. The internal branch is a sensory gland branch to the area above the vocal cords. The external branch innervates the cricothyroid muscle. It's the only muscle supplied by the superior laryngeal nerve. The recurrent laryngeal nerve supplies all the other muscles of the larynx. But that little cricothyroid muscle is a tensor of the vocal cords. So if you damage the superior laryngeal nerve, you've damaged the ability to tense your vocal cords, and you end up with a whispery voice. So damage to the superior laryngeal nerve, whispery voice, because of loss of innervation to the cricothyroid muscle. Now, the recurrent laryngeal nerve is a real problem if you injure it, because you lose the ability to pull those vocal cords apart, but you have intact ability for them to stay together because the cricothyroid muscle is still intact. So the cords end up in a pyramidal position, and you can have possible total airway obstruction requiring a tracheostomy. One way to attempt to reduce the incidence of recurrent laryngeal nerve injury is use monitoring of EMG. And here at the University of Kentucky, we use NIMS tubes. At the far right, with the blue arrow pointing to it, is a NIMS tube, and you can see the little metal portion, which I'm pointing to now, just above the cuff of the endotracheal tube, and little wires coming out of it. When you place this endotracheal tube, we usually intubate with either no neuromuscular blocker or succinylcholine, because the succinylcholine will wear off rapidly, because this tube is actually positioned with that metal portion between the vocal cords. You need those vocal cords to be innervated and be able to constrict and contract if the nerve is being irritated in any way as the ENT surgeon is working. So you don't put lidocaine gel, for example, in your endotracheal tube. Don't use long-acting neuromuscular blocker like rocuronium, and we tend to use the biggest tube we can so that the contact of that metal occurs with the vocal cords. Parathyroid injury can occur if the little parathyroids sit in the backside of the thyroid usually, and can be sometimes inadvertently removed. And if too much of the parathyroid tissue is removed, acute hypocalcemia can occur. Now, it often occurs in about 1 to 2 days after thyroid surgery. So not right after thyroid surgery, but 1 to 2 days afterwards in a small percentage of patients. If a patient who has had thyroid surgery suddenly starts to develop things like tingling around their mouth and their fingertips, and if you blow up a blood pressure cuff in their arm, their hand contracts. If you tap on the side of their eye, right around their forehead area, they can get facial contraction when they're tapping on that 7th cranial nerve, Shopstick sign. Their calcium is low, and the QT interval can be prolonged. So the problem is the parathyroid's been injured so much that calcium levels go down, and so the treatment is intravenous calcium. Airway management may be necessary if laryngeal stridor or spasm results because of the hypocalcemia. The third thing that can occur with thyroidectomy is a neck hematoma, and bleeding into the neck is an emergency. Oftentimes it's noticed in the recovery room, and the patient may require opening of the incision, opening of the muscle, letting the blood come out, the airway to be back into a midline position. Do not put these patients to sleep. Do not paralyze them if at all possible. Keep an ENT surgeon in the room with you, and awake intubation may be necessary. The airway may be impossible to intubate if there's a huge hematoma pushing the airway to the side or constricting it. keyword is jet ventilation complications. And the picture up at the top right is an example of a jet ventilator. There's other forms of jet ventilation. The picture at the bottom shows a cricothyroid catheter having been placed. That little catheter being attached to a manual trigger, attached to an oxygen outlet. As you depress that manual trigger, the pressure from the oxygen outlet up to 50 psi usually is adjustable. You start very low at 5 or so and go up, and jet ventilation occurs through that catheter and through the Venturi effect entrains air. There's also a high-frequency jet ventilator shown here at the bottom far right, and all of those are forms of jet ventilation. We use jet ventilation for rigid bronchoscopy, airway surgery, after catheter cricothyroidotomy. And the types again are the high-frequency jet. There's the low-frequency manually triggered, like the cricothyroid catheter. But the key word was the complications of the use of these. Now you can see that this little catheter is pretty small, and blasting oxygen in there, you can oxygenate pretty well, but over time the CO2 builds up and hypoventilation occurs. And so jet ventilation is usually limited not so much by oxygenation, but by adequacy of ventilation and the buildup of CO2 that occurs. Now if you have total apnea, the CO2 tends to build up about 6 millimeters of mercury the first minute and about 3 to 4 millimeters of mercury each minute thereafter. If there's an increased PaCO2 from the hypoventilation, you can have cardiac arrhythmias and you can have respiratory acidosis occur. Another complication of jet ventilation, other than just hypoventilation, is the risk of barotrauma. Although this is relatively rare, you can have air that gets blasted into the mediastinum, into the thorax, and you can get a pneumomediastinum or a pneumothorax, or both for that matter. You need to give time for the air to come back out. And if you have jetting under high pressure gases coming into the airway and inadequate expiratory time, you can see how the pressures could build up, and pneumomediastinum, crepitus in the neck, and pneumothorax with collapse of both lungs could occur. The next keyword is perioperative blindness etiology, but let's first touch on postoperative ocular complications to put it into context. If a patient wakes up in the recovery room with unilateral eye pain and tearing, and if the lights are on, it really bothers them, photophobia, and if they blink, it really hurts. The picture at the top right is a fluorescein stained eye, and you can see the scratch in that cornea. Very painful, usually unilateral, lots of tearing. Now, another thing that can happen is a central retinal artery occlusion, and if a patient is prone with lots of pressure on their eyeball, they can get this proptosis postoperatively, chemosis, hyphemia, lid bruising with pale edematous retina, and cherry red spot is the classic finding, often occurring, not often occurring, but associated with head and neck surgery. So central retinal artery occlusion, lots of pressure on the eyeball from being prone, and the picture at the bottom right is that cherry red spot characteristic of central retinal artery occlusion. Now, cortical blindness refers to the occipital lobe of the brain being damaged, often after coronary bypass graft surgery that has been complicated by severe hypotension and low flows. So bilateral blindness, they wake up blind. That occipital lobe is a watershed area, and because of the extended periods of low flow hypotension, they can wake up with cortical blindness. Have a normal optic disc and pupillary response. Acute angle closure glaucoma, for example, would be a patient who you know has glaucoma. Maybe you didn't know it was angle closure glaucoma, and in the perioperative period you gave them scopolamine, for example, a patch, or atropine, and that mydriatic drug causes their pupil to get big and makes the iris fold back like a curtain on the peripheral edges of the eyeball and block the canal Schlemm outflow of the fluid in the eye, and the pressure builds up dramatically, and in the recovery room they can have an eyeball that looks dead in appearance. Blurred vision, you've used a mydriatic drug, dead eyeball appearance, think acute angle closure glaucoma. Now let's go to our key word of the causes of perioperative blindness. One of the major causes of blindness is ischemic optic neuropathy. It's a painless visual loss, can be on one side or both sides, frequently associated with spine surgery. It can be the anterior or the posterior variant. Now, ischemia to the optic nerve, if it's anterior, which is the most common, the optic disc can be edematous, and the picture at the far right with the blue arrow pointing to it is an example of a pale optic disc edema with adjacent retina infarcted, and that white, pale, swollen, and hyperemic optic disc, and that's apparently the appearance, although I likely could not pick that up, of anterior ischemic optic neuropathy. Posterior ischemic optic neuropathy is behind the retina, so you don't see it, and the optic disc will appear normal. But ION in general, number one cause of perioperative blindness, often after spine or prone surgery. So the risk factors: proning, spine procedures, GA of long duration in these spine procedures, large blood loss, male sex, obesity, and the recommendations from the ASA Practice Advisory include to mix some colloids in with your crystalloids instead of just pouring in a bunch of crystalloids when you are attempting to maintain intravascular volume. There's no specific transfusion threshold, like a hemoglobin of 8, 9, or 10, but obviously a very low hemoglobin would be associated with potentially low delivery of oxygen to that optic nerve. Keep the head in the neutral position, the head not down below the heart. Oculocardiac reflex is the next key word and involves cranial nerve 5 and 10, trigeminal vagal. And the picture at the top right shows the eyeball with the extraocular muscles around it. When those extraocular muscles have traction applied to them, like the medial rectus muscle, manipulation of the globe with the retrobulbar block, for example, pressure on the eyeball, or even an increase in intraocular pressure can trigger this oculocardiac reflex. And again, in the figure at the top right, you can see the ciliary ganglion, the geniculate ganglion, trigeminal nerve, taking the signal to the brainstem, and then from the brainstem through cranial nerve number 10 back to the heart, slowing the heart, resulting in bradycardia. So the afferent limb is the 5th cranial nerve trigeminal to the brainstem, while the efferent limb is the 10th cranial nerve vagus to the heart. Bradydysrhythmias and hypotension, even asystole, can occur, and it tends to be aggravated by light anesthesia if there's concomitant hypoxia and/or hypercarbia. This fatigues really easily, so if you keep pulling on the eye muscle, it tends to go away or at least be reduced over time. It's not necessarily prevented by giving prophylactic atropine or glycoparylate before the operation, but treated when it occurs and when it's associated with hypotension, treated with atropine intravenously, or just tell the surgeon stop pulling on the eyeball, remove the stimulus, deepen the anesthesia. Atropine, as we mentioned before, and local anesthetic infiltration of the extraocular muscles can reduce this afferent-efferent oculocardiac reflex of trigeminal vagal. The next key word is retinal detachment gas bubble. Under eye pharmacology, it's under that eye pharmacology because nitrous oxide expands sulfur hexafluoride gas bubbles that are used often during retinal detachment surgery. At the end of retinal detachment surgery, that sulfur hexafluoride bubble can be put to the back of the eyeball to help hold the retina in place. aging patient with sulfur hexafluoride bubble is exposed to nitrous oxide, that bubble will expand. You can imagine what would happen if you have that bubble in the back of your eye. It expands greatly. Intraocular pressure could go up. We say avoid nitrous oxide for about 4 to 6 weeks after sulfur hexafluoride use. Some other things to think about regarding eye pharmacology or anesthetic agents. Intravenous as well as inhaled agents decrease intraocular pressure. So pretty much everything that we give decreases intraocular pressure except succinylcholine and ketamine. Ketamine can cause nystagmus and blepharospasm and can actually increase the intraocular pressure. The next group of keywords are related to aging physiology and pharmacology. And in 2018, the green ones were present: aging bowel anesthetics and EEG changes, pulmonary physiologic changes, and the pharmacokinetics of the barbiturate thiopental. In black represents the keywords over the last decade or so on the topic of aging, and you can see that cardiovascular physiology, autonomic and central nervous system physiology, respiratory physiology, and pharmacology are the major categories. But we're going to focus in on the green keywords from 2018. The first is bowel anesthetics and the EEG, and we'll put it under the category of aging in the central nervous system. As a background, the aging patient has autonomic dysfunction. Their baroreceptors don't function very well, and you can have instability of blood pressure, temperature regulation issues perioperatively. When an old person gets out of bed in the morning, they get out of bed very slowly because if they stood up rapidly, their baroreceptors don't kick in as fast, and they could actually faint. So autonomic dysfunction. Their brain mass actually goes down. If they have less cells, their cerebral metabolic rate production goes down. If they don't get as much oxygen, their cerebral blood flow, which is autoregulated with cerebral metabolism, also goes down. So cerebral blood flow and metabolism both go down as the brain mass decreases, but autoregulation is intact. Take both pressure. So there's that flat portion of the autoregulatory curve between cerebral perfusion pressure of 60 to 160, but unless they've had long-standing hypertension, which can shift that autoregulatory curve to the right. Neurotransmitters are decreased: serotonin, dopamine, acetylcholine. And because of this, as well as other reasons, there's an increased sensitivity to many of our anesthetics, and MAC decreases about 6% per decade after age 40. Getting finally to our keyword of volatile anesthetics and the EEG, there's a greater decrease in EEG power, amplitude, and frequency for equal dose volatile anesthetic compared with a younger person, which means basically if you had someone at 1 MAC desflurane, about 6%, who was 20 years old, versus 6% of an 80-year-old, the EEG in the young person would have greater power, higher frequency than would the older patient. CNS aging, continuing on this topic, there's decreased pain perception. Opioids are reduced by 50% because not only are they pharmacodynamically more sensitive, but they also have some decreased pain perception. So pretty much all of our opioids, we reduce the dose in about half. They have impaired thermal regulation, the ability to constrict their blood vessels as well and preserve heat. And so temperatures can be more variable in the perioperative period. And they can also have a risk of hyperthermia because they don't sweat as much, and the threshold for sweating is actually at a higher temperature. Neuraxial blocks, there are some changes. Epidural, there tends to be a spread more of the local anesthetic, and you can get a larger dermatomal spread for the same volume of local that you put in the epidural space. And subarachnoid blocks tend to last a little bit longer in the aging patient. The next keyword is pulmonary changes with aging. The lung of an elderly patient is like an emphysematous patient in some ways, in that it loses its elastic recoil. It's like a balloon that doesn't want to go back to a small size when you blow it up. It becomes like floppy. So the lung is very compliant, and it is at higher volumes. The functional residual capacity is actually higher. Let's look at the graphic on the bottom right to see what happens with age on the x-axis and lung volume on the y-axis. And you can see that FRC is getting bigger as we age. You can see that residual volume, which is air trapped in the lung. We cannot, even with our best effort, get that air out. And residual volume and FRC go up, but closing volume also goes up and crosses FRC at a pretty young age, mid-60s or so, and which means that your tidal volume breathing, as you get to 60s and above, some of that tidal volume breathing is actually occurring at the closing volume, so there's VQ mismatch, and your oxygen in your blood goes down because of that VQ mismatch. So you have a lung that's very compliant with large FRC and trapped air in it. You lose alveolar units, just like an emphysematous patient, so DLCO goes down. And if you measure an arterial blood gas in an elderly patient, it's decreased. There's an equation that you can use to estimate it. It says 109 minus 0.4 times your age will give you the approximate PaO2 for just normal aging effect on oxygen in the blood. There's also maybe a left shift in the oxygen-volume association curve, which decreases the P50, normal P50 being 27, so this would be a slight shift away from 27 towards the lower level, like 25 or so. All of this is debatable. That's airway closure and gas trapping and increased residual volume that we talked about, and there is decreased expiratory flow rates. So we can summarize some of the effects of aging in the respiratory system in the lung itself with VQ mismatch, decrease in arterial oxygen, and emphysematous-like changes with a very compliant lung with gas trapped in it. Ventilatory control, the elderly patient's not nearly as responsive to hypoxia or hypercarbia, where they should respond to hyperventilation when that occurs. The chest wall tends to be less compliant. We said their lung itself is compliant, but the chest wall might be stiff because of arthritic changes, cartilaginous changes, and their muscles are not as strong. So the bellows, the ability to move air in and out, not so great. Conducting airways, not a lot of change. Airway reflexes tend to be depressed, and it's not uncommon to do direct laryngoscopy in an elderly patient, see particles of fluid around their glottic opening or glottic structures. You go, how can they tolerate that? And when you realize that their airway reflexes are decreased, then it makes more sense. Pharmacodynamics versus pharmacokinetics in the elderly. There are many drugs that the elderly have increased cerebral sensitivity to. Propofol, opioids, midazolam are volatile anesthetics. The MAC decreases 6% per decade after age 40. There's no increased cerebral sensitivity to neuromuscular blocking agents. That is, there's no sensitivity to neuromuscular blocking agents, and there's no cerebral sensitivity to etomidate or barbiturates. So let's put aside neuromuscular blocking agents, which we don't need to change the dose per se in the elderly patients because there's no pharmacodynamic increased sensitivity. And at the brain, the barbiturates and etomidate, there is no increased cerebral sensitivity. But you still reduce the dose. In the case of the barbiturates, the reason why you decrease the dose, not because the brain's more sensitive, but because of pharmacokinetic reasons, and there's a decreased central volume of distribution. And to me, I like to think of it as the barbiturate goes into the brain, it just doesn't come out as fast from the brain. And we reduce the dose because of that. A pharmacokinetic reason for reducing the dose. The next group of keywords anesthesia. Again, over the last about 8 to 10 years or so, there's some keywords here, and in green are the ones from 2018. ECT and cardiac effects, ECT and drug selection, donepezil and anesthetic interactions, and lithium and some anesthetic interactions. So let's look at those 2018 keywords. The first one being ECT's effect physiologically on the cardiac system. Cardiovascular effects. Initially, when ECT fires and the seizure starts to occur in the brain, there's initial parasympathetic stimulation. The patient often becomes bradycardia, and the blood pressure can decrease, but this is very temporary. If you wanted to block that, glycoparylate could be given before the ECT prophylactically. Immediately after the parasympathetic stimulation with bradycardia occurs, sympathetic stimulation with tachycardia, hypertension, increased heart oxygen requirements, dysrhythmias can occur. If you want to block that hypertension and tachycardia, esmol is pretty good. Nitroglycerin can be used. Remifentanil can be used as part of your anesthetic drugs to block the sympathetic stimulation that is the secondary component, the cardiovascular effects of ECT. A side note, what happens in the brain with ECT is the brain is seizing, it uses more oxygen, and therefore blood flow goes up to the head, and ICP can actually go up. And so you're not going to do electroconvulsive therapy in those with pre-existing increased intracranial pressure. Other things that ECT does, it raises intraocular pressure and can also raise intragastric pressure. Drug selection for ECT is the next keyword from 2018. Classic pharmacologic management in the past included maybe glycoparylate for patients who would get very bradycardic with their previous ECTs. Brevitol or methylhexatol was the gold standard for a long time because propofol actually shortens the seizure duration with the ECT, and you want the patient to seize. They need to seize for a certain period of time for it to have its beneficial effects, usually on very bad depression. Now, propofol, if you use it, don't put lidocaine with it, because lidocaine reduces the seizure, as does the propofol itself. You may not get much of a seizure. When we use a neuromuscular blocking agent, use it usually succinylcholine in a reduced dose, because ECT only lasts for a very short period of time. You want the patient to return to spontaneous. If the muscles in the body all contracted, there could potentially be fractures of long bones, for example. Esmol may be added to blunt the sympathetic response, and then mass ventilation is usually performed during the paralysis. That's typical to do mass ventilation and not put an endotracheal tube down these patients unless they're at a big risk for aspiration. And then you can do your induction agent succinylcholine tube, but you're going to do ECTs a lot of times, and usually they're done with mass ventilation without an endotracheal tube. Now, the seizure duration is important. Things that shorten it, we want to avoid. So propofol, not a great choice for induction in a patient for ECT, or if you use it in low doses. Midazolam, we use to treat seizures. It's going to reduce the seizure duration, and lidocaine, if we combine it with propofol, or use it in an attempt to try to block the sympathetic stimulation from the ECT, it would shorten the seizure duration. Brevitol, ketamine, remifentanil, esmol, labetalol, dexmedetomidine have no effect on the seizure duration. And if you want to increase the seizure duration, etomidate could be chosen as an induction agent, and caffeine can be given prophylactically before ECT to increase the seizure duration. Now, hyperventilation can increase the seizure duration. Opioids, if we use a little bit of remifentanil and then decrease our dose of induction agent, for example, if you happen to be using propofol, combine it with a little remi so that you could reduce your propofol dose, then your seizure could be of longer duration. And then remifentanil could be used to decrease the sympathetic response that occurs with the secondary component, the classic physiologic response to ECT of cardiovascular stimulation. Again, lidocaine can decrease the seizure duration. ECT effectiveness will be decreased if you used it. A gap in knowledge on the entering exam for 2018, meaning that more than 50% of the people who took the exam at the CA3 level missed this question, was that donepezil or Aricept, a drug used for Alzheimer's dementia, can prolong the duration of action of succinylcholine. Donepezil or Aricept is an acetylcholinesterase inhibitor. So think of it like neostigmine, but in the brain. It's centrally acting and crosses the blood-brain barrier. And it is a reversible inhibitor of acetylcholinesterase, as opposed to ecophthalate, which is used in glaucoma patients as eye drops. And those eye drops in the glaucoma patients irreversibly inhibit acetylcholinesterase and pseudocholinesterase for that matter. So a patient taking donepezil or Aricept for their Alzheimer's dementia has inhibition of acetylcholinesterase and pseudocholinesterase, because acetylcholinesterase and pseudocholinesterase have similar structures in many ways. So there can be an interaction with our neuromuscular blocking agents. So an Alzheimer's dementia patient who's on donepezil, think, if I give them succinylcholine and pseudocholinesterase is inhibited, pseudocholinesterase breaks down succinylcholine, therefore I could have possible prolongation of the effect of succinylcholine. Usually this is less than an hour. Now, non-depolarizers like rocuronium and vecuronium, if you have inhibition of acetylcholinesterase at the postjunctional membrane, you will have more acetylcholine at the postjunctional membrane competing with rocuronium, and so it will require more rocuronium to maintain neuromuscular blockade. So the manufacturer actually recommends withholding Aricept for at least 2 weeks prior to scheduled operations, although I suspect most would not cancel a surgery if someone took donepezil the day before or even the morning of an operation, but just realize that neuromuscular blockade can be an interaction with this drug. The next is the keyword is lithium anesthetic interactions. Lithium is usually taken by patients with bipolar disorder. Preoperatively, you should think of the thyroid potentially being affected. Hypothyroidism can occur because there's decreased production of T4 and decreased deionization of T4 to T3. Diabetes insipidus is associated with lithium because of interactions with cyclic AMP in the kidney, and there can be cardiac changes such as T-wave flattening or inversion on our electrocardiogram. The main point here, though, is that lithium can interact with and potentiate both non-depolarizing and depolarizing neuromuscular blocking agents. It can decrease the MAC of our volatile anesthetics. The next group of keywords we're going to talk about is orthopedics, and in 2018, in green are shown the orthopedic keywords: tourniquet deflation, tourniquet management, tourniquet pain, blindness postoperatively, and the methylation glue that's used in orthopedic surgery. So let's focus on tourniquet management first. A thigh tourniquet is usually blown up to about 100 millimeters of mercury above the baseline systolic blood pressure, and an arm tourniquet about 50 millimeters above baseline systolic blood pressure. We try not to keep that tourniquet up more than 2 hours, because after that it's associated with neurologic and muscle injury. There's some absolute contraindications to inflating a tourniquet on a limb. One would be sickle cell disease. You can imagine if you blew up a cup on a leg, the blood in that leg would be exposed to low oxygen levels, and cells sickle in a patient with sickle cell disease in response to hypoxia. So sickle cell crisis could be made to happen in a patient if a tourniquet is blown up on an extremity. If they have severe peripheral vascular disease, not getting much blood to that extremity already, you blow up a cup on it, they could